So, our final session on the future of healthcare. Very excited for this discussion to look to the future, because it's great, being very busy right now, but we do have to look to the future if we want to create the change that we want to see. And three of our panellists you've met already, but our fourth panellist with an MBA from Leeds University. She co-founded Nutrition Network in 2018 and has been its managing director ever since. Also, as the chief operating officer of the Noakes Foundation, she established the community-based non-profit Eat Better South Africa. Please welcome Jayne Bullen. And then chairing this panel, qualifying as a medical doctor from the University of Cape Town in 1995. He has worked in the insurance field for 25 years, joining Swiss Re in 2011 as the Chief Medical Officer for EMEA region. He became Swiss Re's Global Chief Medical Officer in 2017, where he plays a key role in Swiss Re's medical thought leadership. His research and collaboration with world experts has led to a metabolic health initiative, which he drives with support from various teams. Please welcome Dr. John Schoonbee.
Good afternoon, everybody. I'm really pleased to be here. Sam, thank you for asking me to chair this. It's a really, really important topic for Swiss Re, so the organization I work for. I represent commercial interests, but fortunately for me, it's a commercial interest that is fully aligned with the health and longevity of our policyholders. So getting the world healthy and getting them to be metabolically less ill is a really key thing for us, which is why I'm very connected with a lot of the people in this room. So the future of healthcare. One of the things that a big reinsurer is very worried about, so most of our, exposures to mortality, so people dying, right? So we take these very long bets about how long people are going to live, and then the very clever actuaries work out the premiums, and we hope that they will live to where we expect them to be. And part of that calculation is something called mortality improvement. So we keep believing people will live slightly longer, as they have in the past. And oops, since about 2010, things have slowed down. And that's really worrying us. It's worrying our clients, the life insurers. And this is pre-COVID data. And so the slowing down of mortality improvements is raising very big questions in the industry. And it's something we focus a lot on. And of course, the metabolic ill health epidemic that we see is we believe, a massive driver of this. And so if we can try and shift the needle and get people healthier, that's very good for us and very good for the individuals. So the future of healthcare, Eric mentioned yesterday about the Royal College of Physicians. So if you're here in October, Eric, maybe you could go to this event. I wanted to share 3 bits of information with you quickly. The one is the Economist Impact event, which is happening in October, right, here in London, and 100 plus speakers, 550 plus attendees, content-rich sessions, economics, inclusivity and sustainability, and this is titled the 2nd Annual Future of Health Europe. So my question is, who in this room is going? Who's been invited, right? And when you're going to look at the program, are you? No? When you're going to look at the program, you'll see a lot of names, a lot of people in healthcare, but certainly not a single person that I recognize that knows about metabolic health and knows about carbohydrate and insulin resistance, right? So then begs the question, is that really going to look at the future of healthcare, right? And then I was in Geneva a couple of weeks ago, and I was invited to 2 events. One of them was also an Economist Impact event called the National Obesity Action Plan Playbook that they were handing out. It was an event on obesity. And so there were a lot of people talking about obesity, very, very senior people. And I wanted to read you a couple of things. So it was all about obesity, and they talk about physical activity promotion. They talk about public education and awareness, and nutrition education and counseling. Sustained funding for obesity prevention and nutrition labeling. But nowhere on here do they talk about insulin. Nowhere on here do they talk about carbohydrate. This is kind of the global obesity discussion. And then I went to the World Economic Forum, and there was an event and a meeting talking about metabolic health, right? And it was kind of organized by the McKinsey Health Institute, and I think they're trying to do stuff, because in fact I sat next to one of their people in the morning, and they're changing their focus from obesity to metabolic health, and I went, that's amazing, right? And then I read the, so they've got a paper on the path to metabolic health revolution. Sounds a bit like this kind of event. And I read the whole paper, and insulin resistance is not there at all. Focus primarily on obesity, and if we fix obesity, then NCDs disappear. And in fact, when I went to the event, there was a presentation on metabolic health. And after the presentation, I put up my hand and I kind of mentioned the fact that I think they're missing the boat, because, again, insulin and insulin resistance was not mentioned, right? And I'm just going to read one line out of this summary, this executive summary from the McKinsey report. And it says, they talk about the science. Achieving the latter vision, so this is a vision about improved health and prevention, would require substantial investment, blah, blah, blah. Then they talk about the science. Scientists can advance the understanding and definition of metabolic health. For example, achieving consensus on biomarkers and aggregate measures. Isn't that great? So come on, guys, get with it. So with that as kind of the background, and the fact that 90+% of the adult population shows some expression of insulin resistance, I'm going to start with you, Anthony. So you spoke about you spoke about what the problems were, and I guess in the context of what I've just shared, what do you think the solution is?
Well, I mean, the solution is stop eating garbage that causes disease. That'd be a good first start. But I mean, how do you affect that? I mean, you can do that through education programs. That's what we're trying to do. I mean, through this grassroots movement, we're trying to educate people so that they can improve their own lives. And then we're getting more doctors and clinicians that seeing this, they're affecting this on their patients, and we're seeing improvements. We've got a large enough groundswell that now we're getting more national, international attention as well, and maybe we can get some top-down changes as well. That would be great. And that's the whole idea, behind the MAHA movement now. But I think that's basically what it comes down to, is just showing people that there are certain things that they ingest or are introduced to in their environment that will cause harm. And there are certain nutrients and factors that we need, that we have to have. Food, sunlight, positive forces into our biology that we need to recognize. And so that's at the end of the day, that's what needs to be done. How do we affect that? But I think one of the key thing is finding different private industries like your own industry that has a vested interest in people being healthy as opposed to people being sick. Because right now, the sick care industry is really about making money off of people's illness, and the more healthy people are, the less money they make. So they have a vested interest in people being sick. And the pharmaceutical companies have a vested interest in not curing diseases, in perpetuating diseases and treating the symptoms of said diseases. So those goals are antithetical to a healthy population. So we need to ally ourselves with, industries like your own that actually profit and are have a profit motive to keep people healthy. And I think that's going to be the ultimate way of getting this out there.
Jayne, you and I spoke a bit about your thoughts on this beforehand, and you mentioned education, right? And as Anthony says, if you take an individual person and you show them all the data and information and you explain it to them, then you can effect change quite rapidly and quite significantly for that person. How does one do it at scale, at a population level or at a global level?
So we've been trying for 10 years to scale our programs, which we know work. We work in underserved communities with women with diabetes and obesity in South Africa. And it's very simple. I mean, we get them down to under $2 a day food costs. We have evidence. We have multiple published studies out there now on the efficacy. But can we scale it? Well, no. We haven't been able to successfully scale it. And then, of course, we've got to look at why. And when we start to, this theme of this lecture, or this panel is so important because is what we're doing actually healthcare? Are we asking the right people? A year after we started our interventions, we went to the head of our governmental funding, unit in our province in South Africa, and he just said to us, you guys are doing great work, but really you're smoking your socks. We're trying to get clean water to our people, And how do we scale something that's got to do with, these high-level goals? And I think just in terms of this discussion, what's really important for me is to look at what the root cause of illness is. Why are we getting sick from bread's been eaten for, we know, centuries. Why are we suddenly getting sick from it? And what are we doing to look at health? And I don't know if anyone in this room has heard of the Ottawa Charter. Has anyone actually heard of the Ottawa Charter, the Charter for Promotion of Health? One person. So in 1984, a global treaty was signed. It was a charter that was for the promotion of health, and that fiscal measures would be put into place to spend money on health promotion, not only research into medication and disease. And it had potential long-lasting effects on the future health of the world because it had in there a lot of the measures that John's mentioned now around, regulation, education, all of these things. But very, very few countries adopted it. They just put that money back into research pipeline around disease, research expenditure, budget into other things. And what we've done is we've lost the plot because we know it's not healthcare anymore that we're working in. We're working in sick care. We've spent all weekend talking about disease. So I'm so glad we've got an opportunity now to talk about health in the last panel. What does it mean to be a healthy person? What does it mean to have a healthy system that creates better health? And how do we implement that? And of course, we've created, through the work that we do, we've tried to implement many of those answers. So we've said, well, if doctors aren't trained in, how to have a dietary conversation and actually give patients better advice, then they're just going to keep getting sicker. So we've trained multiple 10,000 doctors around the world that can now start to have conversations in that direction. But we're all scratching the surface until actual fiscal policies and public health policies change fundamentally and the food pyramid changes. Where are we going to go?
So, Dave, I'm going to switch to you because you and I spoke about some of the issues around simplicity and messaging, and in terms of the dietary guidelines, in terms of what we are telling people, how do you think we can fix that in a more appropriate way? Because what we've done so far hasn't seemed to work.
Yeah, we're calling our conversation because obviously this comes up in the field that I'm in. Unfortunately, it's not just that something that's a simple explanation is attractive for how easy it is to understand. It's that we want things to be simple. We genuinely have a desire. We like it when somebody can tell us, oh, it's just about this. This is pretty much all you need to know. And once we hear that, we respond, pause, oh, good, because I didn't really want to learn that much about that particular subject. I'm glad you're telling me this thing that I can now understand so easily, because that's what I wanted it to be in the first place. And so I think about certain terms that resonated with me forever, long before I was in this space, such as empty calories. Empty calories was like a pass. It was like, I shouldn't be having this super big gulp. It's empty calories. But it makes it sound so benign. Like, oh, that's just, yes, it's non-nutrient. it's empty. It's not empty. I believe that that was a very strong contributor to my pathological insulin resistance. And so, yes, as an engineer, we're already anticipating things are going to be complicated. We think, oh, yeah, I'll bet it's a lot more complicated behind those hands of the clock. Sure enough, we open it up, and that's exactly what it turns out to be. Getting people into a place where they're going to be interested in ongoing learning of nutrition, I think is not as hard as it sounds, because I think what we underestimate all the time is momentum, to our benefit and to our detriment. A lot of times the first workout, the second workout, we're like, I'm not into working out. It's just not my thing. We don't actually anticipate that we could get more into the mode of doing it. But by the same token, after we've been working out 5 years, we go, well, I'm just going to take a few Wednesdays off. It's not going to matter that much. We forget that that momentum is another kind of its own. So I think a lot of times, just like with anything else, the earlier we get to people, and the more we get them into the habit of believing these things like nutrition really are complex, and to be more mindful of, dare I say, thinking like an engineer with yourself as being the engine, the sooner I think we can get better results. But we've got to get people thinking about this earlier, and the earlier the better.
Thank you. Damien, I think a lot of people in the room would, and in fact, you know, certainly the people that focus on low-carb nutrition, you know, talk about vitamin D, they talk about sunlight, they talk about sleep, they talk about all these kind of other aspects, right? Your presentation was kind of very deep and very specific about some of these. Do you think there is enough evidence to scale what you're saying and to be giving advice globally to people? And maybe, Jayne, you can jump in afterwards, because you made a comment coming up about putting your water in sunlight.
The evidence is emerging, certainly. So, I mean, what you're asking is such an enormous question, and they only gave me half an hour. You know. I could only do a slight bit of it. The bit that I missed, actually, the melatonin bit, is possibly the most important one there, really, and maybe I should have done that instead. Because that's something, just by getting a decent circadian rhythm yourself, everybody can make a difference to their own life in a general way. So, I mean, I stick by what I said in general. You know, you need to be coherent about it, and the sensible thing is to start there. You have a coherent circadian rhythm, you produce enough melatonin, and everything that works that better. There's a lot of things that people can do for themselves, definitely. And in any case, things are changing, you know. People don't have much faith in doctors these days, really, and to be honest, not often in scientists, because science is so largely corporate these days, with several glowing exceptions in front of us here, who've kind of pioneered an independent way of doing science. And I have to also think about the role of societies, of organisations like yours. Can I throw the question back at you?
Of course.
What can your body do to forward what we're trying to achieve in this room? I think, you see, the solution, really, to all of this is in this room, right here. You know, all the people, the various organisations they represent. This is how it's going to happen.
So I'll attempt to answer that. You know, what can the insurance industry do, or the payers do? And one of the things that certainly our industry works on is data and evidence, and they need that data and evidence. And I've shared quite literally around the world with quite literally thousands of very senior people in the life insurance space, the outcomes of low carbohydrate and ketogenic diets, and the benefits. And interestingly, I always laugh, because I think they probably might become one of the healthiest industries out there, because a lot of them follow that advice. I see them, a year or two later, and they've lost weight and they're in remission. But it's about getting them to commit to doing this for their policyholders, right? And there is a cost to that. There's an opportunity cost for the companies to do that, to communicate with their policyholders and to try and get them to do this. But they need evidence. And typically what we have today is what I would call proxies of improved health, right? So we can look at David Unwin's data, and we can say, oh, look at that, the HbA1c comes down, the weight comes down, the blood pressure comes down, the trigs go down. And as a doctor, I look at that and go, well, there you go. That's great. And I've spoken to hundreds of people who've maintained that for years, if not decades. And again, it's a fair question. The industry says, okay, so that's just a proxy, but where's the actual mortality outcome? Where can we see that there really is a reduction in mortality, right? Because if we don't see that, then there's no point in doing this. And then that's, again, a very natural question. Well, it's not sustainable, right? And everyone's rolling their eyes and sighing, but for the average person, okay, so it's a dietary change, and we know dietary changes are generally not sustainable, right? Typically. We're not talking about the low-carb approach. But even then, you've got food addiction and you've got people that fall off the wagon as well. So the kind of long-term mortality hard outcomes is what we need. And my gosh, I'm working on that. We're really trying to find data sets that can show us that. One of the other things we're doing is we looking in the disability space, so people who have claimed income disability, so they cannot work anymore, and they're getting paid a monthly amount. What we're doing is we're trying to triage those cases, find people who are metabolically quite obviously ill, as that being, and metabolic ill health being a key contributor to that, and we are putting them into programs where they improve their metabolic health. And we are finding amazing outcomes. And there the ROI is very, very clear, because you're going to be paying these people's incomes until retirement age, as opposed to putting them on a program for a few months or a year, and they go back to work. And we've got really, really good outcomes. We're expanding that in the UK. We're hoping to launch that in Australia. And again, once that data comes out and we can show we can share that data with other insurance companies, it'll be very hard for them to sit in their hands and not do that. But so while we do that, and then I do a lot of advocacy work by going to events like this and trying to educate people about insulin resistance. I guess my question to all of you is, and I've said this in a number of low-carb events that I've been in, is it's an echo chamber, right? It's an expanding echo chamber, but it's an echo chamber. And we all sit here, we all roll our eyes at the traditional dietary guidelines, right? At the ABC plate and at the pyramids and everything else you see around the world. I don't know if you know this, Germany, was it last year? Recommend 1 egg a week now. Quite literally, in their guidelines. So, and we laugh at things like that, right? But until we can fundamentally change things like policymakers' dietary guidelines, it's going to be very, very hard to shift out of this, right? And certainly companies like ours and our clients, the life insurance companies, their policyholders might become healthier. But to do this at scale globally for the whole population, we need policyholders, regulators, and dietary guidelines to change. How are we going to do that?
I'll start. So I think what we also need are dreamers, and we need people that sit and create a future landscape for ourselves and for our children that we want. So when my son's family are from Taiwan, and when I lived in Taiwan, I can't even remember why, but I ended up at a TCM clinic that was a state-funded clinic, and it was just one of the most wonderful memories of my life, because it was like going into this utopian hospital where there was an old man with a little steam pot on his leg and nurses caring for people in different ways. And I left with kind of, you know, it was like a packet of, I think, rose petals and lavender, to be honest. It wasn't anything, it was a placebo. But what was it? Well, it was a place that offered healing and nurturing and support and care that was available in the community. And the entire time that I lived there, my connection to health was transformed forever. So my son is 17. He was born in England. He's never been to a doctor, never been to a pediatrician in his life, and he's never taken medication of any kind. No antibiotics, none. And I chose to create that path for him and to walk a journey with him that hasn't been always comfortable and easy. But we have to start to go, what do we want healthcare to look like? You know, I didn't want him to go into a disease process. I see his friends they all take, when he goes on Scouts camps, they actually put anti-inflammatories on the list of things that the teenagers should be taking with them. They self-prescribe constantly. And we have to start to be quite fierce about what we actually believe is right and what we want. And that is about health. The health comes first. So one of the most important steps that we made as a medical community at the Nutrition Network was we said, well, we are going to train coaches. We created it as a medical offering that we really used to actually check people's practice numbers before we accepted them onto our trainings. And that's been the biggest key, because coaches are those people that walk people through the long journey of changing their lives. You know, a diet sheet isn't enough. People go back, they fall off. They need somebody that can hold their hand, and their doctor's not available for that. So I believe that a big part of this is to find supportive communities, and a lot of groups are doing that already here. But we need a lot more of that.
So if any of you have questions, you can start lining up. But I want to open it to the rest of the panel again in terms of how you think we can effect change at scale and change the power, I guess, that policymakers, regulators, and guidelines have.
No, your point's important. Go on.
For what it's worth, I'm a big fan of open debate, cordial debate, where and however you can find it in the public forum. It may sound relatively benign against all these larger forces. By the way, Anthony, I see that you managed to do some of those yourself. At our conference at COSI, we have a panel where I'm proactive about trying to get people of various voices that are not necessarily pro-low carb. Because I think when you actually have these ideas on display to the general public, and you can actually see competent people discussing them, right, where they can best represent the sides that they're coming from for the position that they have, then you actually get a lot more of a cogent exchange of ideas. Frankly, I think a lot of the policy that is affecting us so much is being done behind closed doors. A lot of these decisions that are being made that really have massive impacts on our lives. And so if we are genuinely interested in maintaining the science being on our side, part of that is showcasing it by our interest in engaging, which gets back to the echo chamber statement that you've made, is in being proactive about saying we don't want to be an echo chamber. We want to discuss the science, and you know what, in all ways in which we could be wrong, we want to know, but by the same token, we want to be sure you're just as open to be challenged as well.
Yeah, you know, I was sitting, when I was sitting in Geneva at those two events, I was really thinking, I want to get this room, not this one, the ones I was in there, at a conference or in a closed room with, you know, the likes of Ben Bickman and the other names you all know, some of you here, and for a whole day, and let them listen and discuss and talk. And I guess debate wasn't really in my mind, because maybe I'm clearly biased, but yeah, I think to do that and to have an open conversation, I think is really, really important.
I wish we weren't so afraid of the word debate. Debate's a good word, right? Like that challenge is, I feel like a lot of times when there's a pushback on allowing for there to be just a direct challenge, usually means that the bigger guy wins. That when they've got the status quo on their side, they're saying, hey, let's keep it down. What they really mean is, let's keep doing it my way. So I am a fan of debate. I'm a fan of just opening it up and saying, let's have a debate. Let's have the discussion.
I'll give you just a quick example of, again, and it's not a single debate and then it's over, right? It's a continual discussion. I spoke to a group at a life insurance company that had a big wellness program, right? You've all heard of these wellness programs that, in fact, could have been a health insurer. And the nutritionist who worked there and was kind of heading up the nutrition part of their wellness program, kind of listened to me, talking about low carb and everything else, and a few weeks later sent me a link to a press release from the European Society of Cardiology talking about the dangers of low carb diets. And so I looked at the link, I clicked on the link, I looked at it, and then I looked at the actual the actual article, right, which didn't mention the word danger at all. And then, and what it was an NHANES cohort that they divided into quartiles based on the amount of carbohydrate they had. And they took the ones with the lowest carbohydrate intake, which was, I think, 240 odd grams a day. That was the low carb group, who I think drank 4 or 5 times what the high carb group did, and smoked more and exercised less, and surprise, surprise, died a bit more frequently. And again, I went back to her and I kind of explained all of that. And for me, that's kind of one step. And hopefully that person will, the next time they see a headline, actually go and look and consider to interrogate it, right? To really decide, is it low carb? Is it a fair or reasonable study? So I think education is really, really key. Anyone got burning thoughts? Else I'm going to open it up. Okay, go ahead.
I was going to make the point that Dave said earlier. We need to start young. We need to be starting with... Is this working? Oh, yes, yeah. We need to start young as possible. We need to be starting with Faith Ann there, really. Treating us in schools, and that doesn't look like it's happening, does it?
Well, I mean, certainly PHC is doing a good job with their program, so that's great. Go ahead. Please introduce yourself, and I'm going to quote Graham to kind of keep your questions really short and make sure there's a question mark at the end of it. Thank you.
Hello. Hi, I'm Moira Newis. I'm a nutritional therapist, but I also have a background as 20 years as a senior manager in the NHS. So I come from a slightly different perspective, perhaps. So my question is based on the fact that I believe that in order to change, particularly in the UK, what we're doing with the NHS, we need to do 2 things in particular. One is more economic evaluation of the impact of the clinical changes we can make to get the health results. And I do think the health insurance companies potentially play a really significant role in persuading senior people that we need to make changes. So I think there's 2 things for me. One is, how do you influence the senior policymakers? Because I believe all this comes down to rewards at the end of the day. So it's partly how you incentivize the system to achieve the results. So a great example would be, why don't we have all GPs given a new target of remission for type 2 diabetes, which is something the Public Health Collaboration's been trying to achieve. Okay? That's actually a really simple policy decision. It wouldn't go against anything anybody else believes. Everybody would like to see that. It's not controversial. It might be controversial about how you achieve it, but nobody would argue with it. So there's that side. How do we incentivize a change? Both with managers and clinicians, but also the economic bit I would like addressed. How do we, what do we need to do to change the economic perspective on this for the NHS? Thank you.
Would any of you like to?
I just want to put in there that, yes, it's a disease, but we've got to start to treat diabetes like a lifestyle condition and start to address lifestyle measures. So that doesn't exist in a GP. I don't know if David Unwin's here, but all the doctors that we see that are successful in practice with diabetes reversal lean heavily onto educators and coaches. And we don't need to get to the point where we actually have to go onto drugs and see a doctor.
But to get
long
large-scale
before.
change, we need those targets to be in the health services. Otherwise, we're just picking people off the edge, you know, with these events and things, which is totally great. I get that, and I'm totally in favour of all. But, you know, if we want to address the 30,000 diabetics that David talked about in Somerset, you know, if we had a target for remission for diabetes, you know, it's significant change we're talking about.
Yeah, I mean, I think the remission target is an absolutely great one, and you know, the NICE. So the letter's been written. I don't know if you all know that, right? To NICE to try and change their guidelines to include that as a target. I think that'll be great. That'll hopefully allow that to go in as a kind of a incentive-based target. You know, it's tricky with, and I'm not making excuses for them, but you know, when an entity like the NHS is under so much pressure to carve out money to then go and create a preventative, health-focused program is really, really tricky. And the other side of it is we've had some discussions, and the people making those decisions are often politically bent and have short-term, I want to be voted in again kind of mindset, right? And I think that makes it very hard for them to have this long-term approach. I'm not making excuses, but that's kind of the reality, I guess. And Jayne, you know, talking about we shouldn't, you know, diabetes shouldn't be a disease, it should be a lifestyle. I mean, the whole world's gone, obesity is a disease. It's a disease, right? Like, that's the whole narrative out there. And so we're almost going in the opposite direction, sadly.
All we're ever going to be doing is mopping up disease with drugs.
Yeah.
I do think, though, that it's just as an example, sorry, I will shut up in a minute, but if you made the target, you know, I've been a partner in a GP practice from a management point of view. We know we sit down, we discuss how we achieve these targets, right? We know we're desperate to kind of get all the money in that we can as a business. You know, there's practices will sit down and have these conversations. They'll look at ideas, they'll look at what other practices are doing. So there is definitely something there about change at the coalface by changing the reward mechanism being something that I think we should be trying to promote at a political level. I don't know how we achieve that, but I definitely think we should be aiming for it. So
Yeah.
I'll sit down.
Thank you.
The problem with affecting things politically is because there's so many other motivations. I mean, we're not in an altruistic world where everyone's trying to do the best thing for humanity. Maybe that something like that existed historically, where people recognized that your populace you were better affected as a country if you had a healthy populace. That is not the case anymore. There's too many invested interests. I mean, like in my talk, there's $13 trillion a year for direct and indirect costs for just those 5 chronic diseases, right? People are making a fortune doing this, and they can buy and sell politicians. You know, you look at the American Nutritional Guidelines Committee, there's 20 of these people, 19 of them have significant financial ties to big food and pharma, right? So, you know, we have money tied up in all of these policymakers. Now, you can get things in there. You can get a grassroots movement big enough that you start making enough noise that it makes political hay to listen to it, and that's starting to happen. And then you'll have enough people that are affected by this, understanding the science, seeing this in their own practice, and all of a sudden you're getting enough people, and they get into these positions that they can actually affect change. That's happened in Australia, where I practice. There's Dr. James Mukey, who was awarded the Australian of the Year, I think in 2020, for his charitable work as an ophthalmologist. And because of he was named Australian of the Year, they said, hey, do you want to be on our diabetes panel? You know, we're coming up with the new guidelines for diabetes. And it was just like, he was like, all right, I mean, I don't treat diabetes except for diabetic retinopathy, but he knew about the low carb, and he knew about the data on diabetes and low carb. So he was sort of like this Trojan horse. All of a sudden got in there. He wasn't supposed to be in there. He got in there because he was Australian of the Year, and they wanted his name on that panel. And he fought tooth and nail to get carbohydrate restriction, ketogenic diets on the National Register for treating diabetes. And he came up against stiff pushback. People that almost certainly had financial ties were fighting tooth and nail to keep that off, and he won in the end. He won over the rest of the panel, so they put it on there. It's been so successful now in Australia that ketogenic diets have been now upgraded to best practice for treating diabetes in Australia. So now clinicians like myself and others who affect these interventions for our patients, we're covered now. This is mainstream medicine now in Australia, right? So that's the way you can do it. And but there's so many tentacles wrapped up guarding this very precious industry, which is making people tens of trillions of dollars. You know, the pharmaceutical industry is making tens of trillions of dollars, well, the whole medical establishment is making tens of trillions of dollars, and the food industry, the processed food industry is making trillions of dollars as well. So this is not something they're going to give up easily, and they own a lot of people. So we have to have as big of a grassroots movement as possible, and then we start having more organizations, more clinicians, and more people involved that understand this. We make enough noise that they have to pay attention politically, and we start getting people on these panels that are actually going to try to affect positive changes for people, not just support their their financial ties.
Thanks.
Hi, Campbell Murdoch, GP, and I spend my NHS time in a practice in the southwest of England where we have 9,000 patients, and this is owned by an organisation that covers 260,000 patients. And we now have massive momentum building in metabolic health in that practice. And John, actually, that's thanks in part due to your UK team, and your influence has really pricked the senior leadership's ears up. My last patient on Friday before I came here, 88-year-old lady with crippling osteoarthritis, came in, sat down and said, I want to do that metabolic health thing, which is wonderful. And the reason I share that is I have discovered for myself the two things that have unlocked this ability to shift the population has been changing the framing from low carb to metabolic health, and also focusing all effort on putting the foot down, not battling, which means we can just go out into the community, put events on, people are learning. So the question is, what on your journey so far have you learned is not what to do? And if you learned something from that, what did you do instead?
Anyone want to go? Not to me, right? It's the panel.
I'm going to answer on behalf of my friend Professor Tim Noakes and say, best not to talk about breastfeeding and infant nutrition. Just keep it out of that area for now.
That created some momentum, though, back for the world. So the question really is, we're on a journey, aren't we, of how to create maximum social change, really. And there are things we go out doing thinking we're going to have an impact, and you find out 4 years later you've just spent all your effort battling with some guy down the corridor who disagrees with you. And then you learn to change the framing, do something a bit differently, and suddenly you realise that same amount of effort creates a lot more momentum. What's the learning so far? Because I think the solutions may be quite easy if we redirect and frame things in the right way.
In a way, we should be asking Tim Noakes, shouldn't we? You know, he'd be a very good contributor. Do people here know the story? Yeah, right. Oh, I see. Right, yeah.
So I'll share what I found is, because I've been talking about this for probably about 10 years plus, and a big change in my organization was when I started talking about metabolic health and insulin resistance, because everybody wants to be metabolically healthy. It just sounds good. And then you explain insulin resistance and everyone gets that. And then, of course, at the end, you get to carbohydrate restriction, right? And then you get to ketogenic diets. And then people go, oh, well, that's dangerous. And then you go down that path and try and explain to them that it's not, it's natural. But when you start off with metabolic health, you continue the conversation for a lot longer, you get buy-in, as opposed to starting off with low carb and ketogenic. So for me, that has been a real benefit.
I can just say on a one-on-one basis when I'm seeing patients, obviously I'm in a very specialized practice. I'm in a metabolic health practice. I see people that have not had very good results with, standard of care, their normal GPs, specialists, things like that. They're just sort of getting worse. They're getting sicker. They're getting on more medications. They're not getting better. And then they hear about their friends or their family that are getting better, and they're doing some weird thing, and they're getting better, and they're coming off medications. So they come to me. We talk about their personal issues, all the things that they're trying to address. We might do a deep look in their blood panels, metabolic health, hormones, nutrients, these sorts of things. And that gives me a lot of information, about them, but also I can use that to show them just what's going wrong in their body and relate that to their lifestyle and their dietary choices as well. And so you have someone come in, you talk to them about insulin resistance and insulin, how this affects hundreds of different things in the body, and how glucose directly damages the body through glycation, and all the different consequences of diabetes are typically from elevated blood sugar, damaging the vessels and organ damage, all these different sorts of things. You can just relay that to them. You show them, look at this, you're fasting, blood sugar is significantly elevated. You have diabetes or pre-diabetes, or maybe they don't yet. Maybe they have an insulin level, fasting insulin level that's 30, 40. I had one gentleman who's 72. It should be under 9. I really wanted around a 5, right? And it affects everything at a 72 now, and then they eat something and it jumps up higher than that. So you can point all these things out to them. You show them their hard numbers. Like, look at this. Like, this, you should not have this above 9. You're at 72. That's not what you want. All these other things are out of balance because this is 72, and this affects this hormone. This affects your leptin. This affects your growth hormone. This affects your testosterone. This affects your all next blah 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 blah. And you can point them out in very real one-to-one sort of terms. It's like, this is how this is affecting you, And I really like Dr. Unwin's explanation when he talks to patients. Say, okay, look, you have diabetes. This is what this is going to mean. These are going to be the consequences. This is, you can be on these medications. We're going to have to increase them over time. You're going to have this decrease in life expectancy and morbidity. You're going to get all these problems. Or we can restrict carbohydrates and you won't need any medication. They're like, yeah, let's do that. So, when you frame it like that and you show it in a personal one-to-one basis, like, look, this is your blood, like your symptoms that you're having, they line up with what you're telling me about, and this is what I'm seeing in your blood work, and you can make a very strong case for these different sort of lifestyle interventions. I have yet to have a single person that's coming now. I have a very specialized practice. I have a very highly motivated patient population that's coming in because they want something different. What was going on before didn't work. They are willing to listen to something new, and that's very important. That's not your typical GP patient. But either way, every single one that I approach in that manner, every single one is at least willing to try it. Not all of them are able to stay on, but all of them try it. Some of them go off and they go like, oh God, I felt so much better when I was doing that. Yeah, I was losing weight. I was, this was getting better, that was getting better. And they at least have that frame of reference. They can always go back to that. It's like, look, you've done it. You know what it is. You've seen the results. Now you came off of it and all these things came back. So there's this cause and effect relationship. You've seen that yourself, and at least you have that frame of reference. And typically, people do stay on track if you sort of stay on them. But that's the way I approach it on a one-to-one basis. Yeah.
Great. Next question over there.
My name's Ifani Osiebu, and for obvious reasons, I'm known as Iffy. I'm one of these annoying podcast people. And my question is, how do you tie in healthcare with farmers? Because they're the source, right? If any kind of ultra-processed food giant is going to come and basically put a stop to the low-carb revolution, are they not going to squeeze it at the source? And the other question to ask is, what does research funding look like if the low-carb revolution wins, effectively? What does it look like in terms of funding? Who's going to be funding it? What's the ideal and what's the practical?
Well, I mean, funding, you get NIH, other sorts of like governmental grants. You could be directing research, funding in that direction. Like, the private industry funding, which is a large portion of research, is it would have to come from industries that would benefit or had a philanthropic sort of bent. But yeah, I mean, I don't think Coca-Cola is going to be researching ketogenic sort of diets, right? But they do attack people. I mean, the cereal companies and processed food manufacturers have explicitly come after people that perpetuate a low carb way of practice for doctors. So Dr. Gary Feck, who's a orthopedic surgeon down in Tasmania in Australia. He was doing amputations for diabetic patients, which is a nasty operation, having to cut off limbs and things like that, hearing this clunk of someone's leg chunking into a trash can. It's unnerving. Not many people wanted to do it. He decided to take the bulk of these cases because someone needed to, and no one else wanted to do it. So he's seeing this, and it's awful. And he was just like, okay, how do I help these people? And he started going into more low carb sort of approaches. He started affecting this to his patients, and they started improving. They started reversing their diabetes, and instead of having to take off a leg, you only had to take off the front part of their foot, or maybe nothing at all. And then for his the patients that needed joint replacements, he said, okay, we'll put you on the schedule. Your surgery's in 3 months, but until then, you are on this diet, and you will stick to it. And the ones that were able to improved a lot. Some of them even called him up after 2 months and said, hey, you know what, I don't think I need surgery. My shoulder's fine, my knee's fine. He said, oh, yeah, no problem. Just give me a call if you need anything. He was targeted directly by the cereal company. They actually sued for the minutes of these cereal companies that said point blank, this damn ketogenic movement is killing our cereal sales, and we need to shut it down. And so they talked about different sorts of people around the world. It's like, we need to attack these people. We need to get their licenses pulled so that we can discredit them and say, see, this is just a quack who got his license pulled. It's not a real doctor, right? And they named Gary Feck by name. I mean, he had 4,000 people following him on Instagram. It's not like this massive influencer or anything like that. They came after him personally, and they were major funders for the Australian Dietetics Association. And the head of the Australian Dietetics Association called the CEO of his hospital and said, you need to shut this guy up, you need to shut him down. And they got one of their nutritionists down there at the hospital to put in a complaint against him. And he spent years fighting that and spent hundreds of thousands of dollars defending himself. He ultimately won. But that is exactly what they're doing. They're absolutely, I've had, it's now 6 attacks on my medical license in Australia. Not for anything I've ever done as a doctor. I haven't had a single complaint about anything I've ever done as a doctor. It's all for spreading misinformation online. That's what it's about. And so, yeah, that they're absolutely doing that, which is why I'm as vocal as I am, because F them. Like I'm going down swinging.
Thank you. Thanks, Iffy. So we need to keep our answers short because we're going to run out of time. We've got a lot of people. Any comment on the farmer as the source of food?
I want to just make a little bit of a controversial comment on that, and it's that, yes, we absolutely are worried about the health of our soil. We're worried about the micronutrients. We all want to eat organic, pasture-raised, all of those things. But when we look at the gross ill health in the majority of populations, talking about my own country, but I think it's not dissimilar to the North American population and many others, it's the broad brushstrokes, it's the 80-20. So we don't tell people that come onto our township programs to eat pasture-reared organic eggs. We tell them to just eat the cheapest eggs they can find, and they can't afford butter, they have palm oil. It's like, so we get very specialized and precise as we go on this journey, but the realities out there are like such broad brushstrokes that we have to address.
Thanks for that. Go
Hi
ahead.
there. My name's Jason Yon. I'm not a medic at all. I'm a research academic, engineering research academic. I accidentally stumbled into this about 2 years ago when I tried out a carnivore diet and accidentally cured my lifelong severe asthma. And I've been a bit of a junkie on all of this stuff ever since. I'm also a lean mass hyperresponder, it turns out, so I've obviously got a specific interest in cholesterol. I happen to think that in terms of the narrative, cholesterol is the stick that the other side most effectively uses to beat us. So they very much appreciate your efforts in trying to solve this. So I've got sort of two questions for you. One of my research areas is measurement uncertainty. Do we have a clue about the measurement uncertainty of the CT coronary angiogram data? And the second question, which might be a little bit provocative for you, there doesn't even seem to be, sort of outside of your sphere, a broad consensus on what's causing the lean mass hyperresponder phenotype. For what it's worth, I think the lipid energy model is quite credible, but what's the next best hypothesis for what's causing it?
Yeah, so on the first question, let me actually do the second question first. The next best, it's interesting because for so long, the saturated fat thing, getting back to the simplicity, I genuinely couldn't believe that there wasn't at least a broader recognition that if it really was about saturated fat, going back to the Atkins days, there'd be lean mass hyperresponders everywhere. Because at that time, people who were heavier were going on Atkins, and it didn't become a lot more common to do keto, particularly for people who are like leaner and more athletic, until quite literally the last like 5-10 years. And so in that regard, when more people are confronted with the BMI association, which the lipid energy model predicts, there doesn't seem to be even a close second. Now, I did become aware quite literally in the last few days that there's a study under registration that's trying to see if they can find where leaner folks are exhibiting this, and they are trying to track, for example, VLDL secretion and synthesis, which I'm very excited about. I can't wait to hear more on that. And sorry, what was the first question again? It was
Any idea about measurement uncertainty on like a single CTTA?
Yeah. So again, this is another place where I have to be mindful, because even for as much as I've learned, this is where I would defer back to the imaging experts to the degree that I can. I knew a common question I might be getting after my presentation is, where do you stand on the certainty level with regard to, for example, the quantitative analysis? And I just emphasize that it's a thresholds thing, right? So there's there's a high level of confidence that I, Dave Feldman, can personally have in any given data set. But with that reference towards my level of expertise for where it's at is somewhat limited until we work our way further in. So a lot of this is being investigated right now, but it's part of why I'm having these discussions with cardiologists, especially those with imaging, even outside of our team, to better understand what's happening.
Thanks, Jason. Eric.
Lean mass hyperresponder question. Eric Westman, Duke University, North Carolina. My first response to you doing this study is, like my colleagues, oh my God, wait, there's someone with an LDL of, 590 in there? And
592.
And they're not dead? So my colleagues, they will shake. My patients tell me stories of them shaking. You need to be on a medicine for this LDL. One of my patients was fired by their doctor because they didn't go on a drug for the LDL. When I looked at the data, I thought, thank God nobody died. Thank God nobody died. No, you think this is funny? How many of you have been bullied about your LDL? So my question for you, is this clinically significant? It's statistically significant. Is it clinically significant? And that means it wouldn't occur to a radiologist to do the same test twice, to see the retest. It wouldn't occur to them. Because you have to give the radiation. It's such a terrible thing. So you need to do the test again and more. I'm reassured by what you found so far, but is it clinically significant?
So, of course, Eric, I can't answer that question. I'm not a doctor.
Right, so when I saw Matt Budoff talk about this in an extended interview, he said, yeah, it was a minimal change, in his accent. It was a minimal change. It was like, what's the big deal? And anyway, so he's got to come out, or you got to have a paper or something that tells the clinical relevant, meaning, what do we expect in other people with this kind of test with change? What if you're actually measuring something with better resolution than ever has been measured before? So anyway, I'd like to see that in upcoming talks or papers, please.
Well, this is why I would hope everyone would welcome further analyses. Like it just as with any experiment, if you've got two different data sets that you already anticipated would agree with each other and they don't fully agree with each other, what would be the objection to getting a third set? But surprisingly, I've actually been getting a lot of objections to us getting the third set, even though it's part of the pre-registered endpoint or pre-registered methodology.
If you have informed consent, just ignore those other detractors. But remember, the upshot is if you have an elevated LDL, even up to hundreds above what the doctor thinks it should be, so almost 5 times, these people were alive for at least 5 years, at least 1 year fully documented, 5 years, even more. And so please don't worry if it's your first month and the doctor goes in and, your LDL went up, you're dying and you need a pill. But that's the reality. Thank you so much. Now, my bigger comment. We just spent 2 days talking about glucose. Yes, you can do ketones in the GKI, but most people can't measure ketones. That's a limitation. We heard that in the clinics. 100 years ago, they knew cutting sugar and starch out of the diet would improve type 2 diabetes and type 1 diabetes. They didn't know insulin was elevated in type 2s yet. And they were measuring urine glucose. There's a roadblock at the policy doctor level. How many of you have used a CGM to measure your own glucoses? Give the public CGMs. Yes. Give them a CGM, either this one or work on a glucose watch that gets good enough, not perfect, and we're not measuring insulin here, and then people will change. It's not up here, down. It's a grassroots change. Yeah. Well, now, I'm not just speaking of this wonderful anecdotal, how many anecdotes you need to ignore. I'm talking about pilot data that's published. You hand out CGMs. These are papers that are being done. Does that count as evidence? Do your people count reversal of diabetes as a proxy for life extension? Yeah, okay, well, but don't wait for that. Just give the measurements to the people.
So thank you, Eric. That wasn't a question.
I wonder what would happen if we gave CGMs.
So I've commented about this and written about this, and I think it'll be a complete game changer. I think if the Apple Watch or equivalent can measure glucose, it will change global health, period. Because I think people can inform themselves so much more effectively. So I think that's huge. And we've spoken to a lot of really high-tech people who actually build the devices for Apple Watches to try and figure out when this might happen, because we've been told this for the last 5 years. Really tricky technology to actually put this in a watch. But there's still hope, but it's very hard. So,
thanks, John. Kind of in a similar vein, I'm also a lean mass hyper-responder, age 72. Maybe I can help your mortality statistics in a short while. And I'm wondering how you can get these accelerated mortality statistics. To go a little bit further than Eric, give them the mojos, the keto mojos, but give them a good % reduction of premia to incentivize them and then monitor them. And I was just thinking in Isabella's tremendous presentation, she talked about how her research, they took a photograph and sent in their statistic every so often. You could monitor, because monitoring would be your difficulty. It's easy to be keto for a week to get the insurance. And the other thing, a query for yourself again. Life assurance, you want us to live longer, but for pension policies, do you want us to die quicker? And also, I was thrilled to actually see somebody like your presence here, because the insurance and life insurance pensions, you're a big commercial hitter in the world in global terms. On a scale with the big pharma and big ag, I thought that, and I think you're in a position to take them on by doing what we're suggesting.
So I want to keep my job. I don't think we'll take them on, but we're, from a market capitalization point of view and a turnover point of view, we're nothing compared to the food industry. It's quite astonishing how big the food industry is. In terms of the incentivization, giving everyone Keto Mojo and measuring, GKI, fantastic idea. Discussions I've had many times with people, but the actuaries are going to go, okay, so we're giving them a discount. We need evidence that there's a reduction in mortality. We really are working very hard, and we've got some early data sets that we've figured out. There's some others I'm working on, and I mean, of course, directionally, it's the right way, right? And my hope is that we're going to be able to convince the industry that there is a significant improvement in mortality. And Swiss Re is mortality overweight as opposed to longevity, so the pension fund side. So we want people to live longer. Okay, go ahead. Sorry about that.
No, Anthony, you made a great statement about the immorality of the food and drug industries, which is what you indicated. Do you think the insurance companies are part of this? Is there any real incentive to lower health policies?
Is the question for Anthony or for me?
No, it's for Anthony.
Okay.
I want to know, what do you think? Because, this doesn't just involve the food industry. It doesn't just involve the pharmaceutical industry. Who's writing the policies for these sick people? Right? Think about it. This is a big scam. The whole thing is a scam, right? So, listen to me. If people did what the folks in this stadium have heard, health is going to improve significantly. Will insurance policies go down? Who is anyone excited when their industry starts losing money? Right? Think about it. Now, I know it's a tough, but it's grassroots. Ain't going to come from the government. They're all bought off. Ain't going to come from the pharmaceutical. Ain't going to come from these other institutions. And what are the insurance companies going to do? People get healthy. Who am I going to write? What do I need insurance policy? I'm really healthy. Right? So, I mean, we're dealing with a very powerful industry. You saw what happened to the one guy you had. They tried to throw him out. Right? So it's got to come from people. It ain't going to come from these others. And then all of a sudden, all these industries, then what happens to the wealth of nations? Think about it at a bigger scale, right? Western societies are wealthy because a lot of people make a lot of money and pay a lot of taxes. Everybody gets healthy. Taxes, think about the ramifications of all this in a bigger way. So what I'm saying is we have to be careful about how we work through all these different systems. But ultimately, it's got to be some from grassroots because, as you said, we need more data. We got plenty of data. So the question is, you know what I'm saying? He knows. We all know what's going on here. Yeah. Anyway. Yeah.
Well, I mean, certainly that. I mean, there's going to be motivations, across the board. Like at the moment, it's not necessarily, in the government's best interest to keep people alive, healthy, and well for a very long time. I mean, you have Social Security age, retirement age, and then all of a sudden you're paying pensions. They don't actually want people being a burden on society past their productive years and things like that. And so, I mean, there's going to be incentives in that direction as well. The medical insurance companies, if people are healthy and better, then they would shrink slightly. People just need sort of major medical. Now, the one thing that is curious to me is the public healthcare systems. why aren't the governments fighting for this? Why isn't the Australian, the NHS, all these sorts of things? They spend a lot of money. There's always a budget crisis and all these systems. Why aren't they fighting for this? They're the ones paying for this. Why aren't they trying to incentivize people getting healthy so they don't have to pay? They can just tax you and just keep that money and do whatever they want with it. That's interesting to me, and I think that there are a lot of incentives, to the politicians and things like that they're sort of working with these different industries as well. They're being manipulated in certain ways, but there are incentives to doctors in certain ways as well. You get sort of kickbacks from the medical insurance companies. If you have a certain level of prescription, you have your diabetic patients on insulin, on this, on that, you're going to get kickbacks. I talked to a friend of mine. He's on he's keto. He had diabetes but he was reversing it and he was getting better. And his doctor said, "Well, we should put you on some insulin." It's like, why do I need insulin? Like, everything's under control. Like, wow, just a minimal amount. He put him on 5 units of Lantus, which is sub-therapeutic, right? So it's just like, but it was just to get him on insulin. I asked him because my friend actually was a medical rep. I said, and he's like, "I don't know why you put me on insulin." I said, "Okay, what do you pay your doctors to get them on 85% prescription rates for whatever you're pushing?" It's like $15,000 to $20,000, just bam, like that. And they do it by incentivizing the practice, and then there's kickbacks and rebates to the practice, and then they get a bonus, right? So it's not a direct from the pharmacy. That's how it's hidden.
Anthony, sorry,
Yeah.
I'm getting.
Sorry.
I just need to respond to that quickly. So I was very much focusing on life insurance, right, not health insurance. Health insurance is a different animal, and certainly it varies a lot in different markets in different countries. In many markets, health insurance is literally a margin game. So the company makes a percentage of whatever turnover gets put through, right? And clearly there is not really an incentive to reduce that turnover. But we must remember health insurance as an entity is amazing to have, right? If you walk out in the street and get hit by a bus and you go to hospital and you go to ICU and you have major surgery, you can be very happy to have health insurance, right? So we mustn't kind of throw out the baby with the bathwater. I've always felt, if health insurers didn't have to spend all this money on chronic conditions, they'd have more money for prevention programs, and they'd have more money for helping people that really didn't need it. So, I think we just shouldn't tie everybody with a kind of a negative brush. So I think we have one more question, I'm told. Please go ahead.
Hi, thanks, and thanks for the great day of speech. Talks, they were wonderful. I'm Sue Beckers. I'm a public health collaboration ambassador and also a Nutrition Network certified practitioner too. Thank you, Jayne. You were talking about getting the message out, and you need to get it out young. And there is a project in public health collaboration, Real Food Rebellion, and I'm really, really pleased to say that we've been working on getting a teaching program out to secondary schools and primary schools, a primary school program. 700 primary school students will be doing it on Tuesday, teaching them the difference between real food and ultra-processed food. And we want, apart from Faith Ann's absolutely brilliant talk, I would like to ask each of the panel, what message would you like to make sure goes out in our final programme when we actually publish the completed one, when we've got the feedback from these schools? What message would each of you like to give young children that you think would help them to change the adults' minds who are feeding them and help them to make them really want to do things differently themselves?
Thank you. That is a great question to kind of tie up the panel. So I'll let each of you go, and maybe just to say I have a colleague in the UK in our London office who in fact is trying to get your program into her kids' schools. So it's a fantastic program. So I'll start on the far side. Dave?
Yeah, actually, and if I could just take it to the larger arc, Jayne, I so agree with your larger message. I appreciate that there's so much interest in trying to influence healthcare at the highest levels with doctors and so forth. But I know this from my own life, and I'll bet many of you do as well. I have challenge cases in my family, and it's not just about telling them what the right macros are. They have people in their lives. They have events that they go to. They have a spouse who may not be as accommodating. And for many of those cases, they usually just need one person who they know is like their collaborator in their own health, and who maybe it's just a Facebook friend, maybe it's somebody who they chat about on the phone every once in a while, but who they know will be disappointed if they get off it. In Alcoholics Anonymous, you'd call this a sponsor, right? It's just often just one person. If you just have one person, and it may not be somebody like a doctor who just doesn't have that kind of time. So hats off to all of the health coaches and nutritionists and everybody who just maintains that presence in lives, because I think it's so crucial. I think that middle layer doesn't get nearly the level of attention it deserves.
Thank you.
So obviously I would want them to learn about low carbohydrate nutrition, but on a much bigger picture, I would want them to understand that what triggers them to make unhealthy choices, because that's what drives illness. So over those 20 years that people become diabetic, it's not the food that makes them sick, it's their decision and reaction to something that's going on in their life that leads them into dysfunctional eating. And we see it carrying on and on and on. So if we could stop that at childhood and teach children how to regulate their nervous systems and eat from a calm and parasympathetic space, I think we'd have a healthy future.
Thank you. Damien?
Yeah. A very simple message would be, teach your parents, organise, be a team, and you got this.
Thank you.
I'm not too sure what a great message would be for kids to take their parents, but I mean just impressing upon kids that this is a really rare opportunity that they have to be as healthy as they can possibly be and develop to their genetic potential that they'll never get again. You only have one chance to develop, and eating properly and living right and exercising, getting out in the sun and doing all these healthy things, they will grow up bigger, stronger, smarter, more intelligent, more athletic, and they will get to continue that for the rest of their life. We're all screwed except for little Faith Ann. We've already developed, and none of us have developed to our genetic potential, none of us. And so we can optimize where we're at now, but they have a very special opportunity to actually improve their development and outcome, and just to impress upon them how important that is.
Thank you all.
So, panel, thank you very, very much. I'm getting daggers from Sam over there.
Excellent.